Okay. That's good. I'll have to do that every time. Dimming the lights for the recording. Okay, so thank you all for turning up today, even though you could all be at the horse races. So I thought that we would continue on and finish the lecture from yesterday because I recognise that there was an animation in there that does need a little bit of explanation. And the other thing too, just when I think most of you are here, is when I was doing the introduction, the very short introduction to the unit yesterday, what I also failed to mention, which is different from previous years, is that there is actually an attendance component for the practicals this semester. Okay, so you need to attend 80% of the practicals to be able to be eligible to sit the final practical exam. Okay, so obviously if you are very, very ill and you're coughing and sneezing and splurting microorganisms everywhere, we don't want you in the laboratory, but otherwise you are expected to attend. Okay, so we'll continue on, and because the portable mic is died, I'm going to have to be standing behind the lectern today, so I won't be able to move around as much as I usually do. Whether this is a good thing or a bad thing, I don't know. Okay, so we'll get on and finish this from yesterday. So you may recall that yesterday in our two lectures we had an introduction into anemia where we looked at the different classifications of anemia, where we looked at the two main classifications that you need to know, which are what? Can anyone remember? Tell the person next to you if you're not sure, the two main ways that we classify anemia. Yep, so morphological, what the cells look like, and what else? Pathophysiological, so what happens to the cells. Yep, okay, so they're the two ways, main ways that we classify anemia. And then we went on to look at microcytic anemias in the guise of looking at conditions of iron dysregulation. But it is important to recognise that not all conditions of iron dysregulation result in microcytic anemia. Okay? It's just that iron deficiency anemia does, and as we discovered yesterday, it is the most common anemia, a common cause of anemia worldwide. And so that's why we tend to look at microcytic anemias and iron dysregulation at the same time. So we looked very much at iron deficiency anemia, touched a little bit on anemia of chronic inflammation, and we'll touch more on that today. And we also had a look at sideroblastic anemia. So you can see that sideroblastic anemia is not only is it included in anemias due to iron deficiency, but we also include it here because it is actually a condition of iron overload. If you recall, you may recall that we looked at ringed sideroblasts. Is that name familiar to you, that term? And so they are the normoblasts in the bone marrow that have the little rings of iron that are incorporated within the mitochondria that surround the nucleus of those normoblasts. And so that is why we have an anemia, because the iron is not able to be utilised, and so we get dyserythropoiesis. But we don't, when we look at iron studies, our iron studies do not reflect that there is a deficiency in iron. In fact, we have an increase in the iron that is in the body, so in our iron stores. So that's why we call it, it is also classed as a condition of iron overload. But what we're going to consider here and what we're going to finish this lecture about is hereditary hemochromatosis. So I'll just get up to my spot in my notes. So as the name implies, this is an hereditary condition. Some sideroblastic anemias are also hereditary, but they can also be acquired. So the other forms of iron overload, where we look at increased intake of iron and increased transfusion load, these would both be considered as acquired conditions of iron overload. So in all of these conditions, what's happening is, for various reasons, we have got too much iron in the body. And too much iron is not a good thing, because iron is quite a reactive ion and it tends to cause all sorts of oxidative damage within the body. So it's not a good thing to have. So hemochromatosis, it is an autosomal recessive disorder due to mutations in genes that encode for the proteins involved with iron metabolism. So the first genetic mutation was discovered in the mid-1990s, and it was a gene that they called the HFE gene, which is the hereditary hemochromatosis gene. And it's found on chromosome 6, as you can see there. And just linking this to the end of a slide at the end of your notes, you can see here that since then there are a number of different mutations have been detected. So they all produce what we call a hemochromatosis phenotype. So hemochromatosis type 1 is with the HFE gene, the first one that was discovered, and it is the most common form of hemochromatosis. The main difference between these from a clinical perspective is the age of onset of the symptoms. So you can see here that the most common form of hemochromatosis, the age of onset is 30 to 40 years. So in this HFE gene, two mutations, there are two main mutations. The first and the most common one is the C282Y mutation, and then the second is the H63D. As you can see, approximately 80% of patients are homozygous for that first mutation. It's most common, hemochromatosis is most common in adults of Northern European descent. Having said that, though, the frequency of the gene is far more common than what you would be led to believe by the clinical signs and symptoms and the diagnosis. So the disease isn't as common as it should be, basically. And so what this means is, just having the gene doesn't mean to say you're going to get the disease or the disorder, but it's a risk factor. It's a huge risk factor. It really increases your chances of developing the disorder, but it's not the only risk factor. Okay? So other things such as other physiological conditions, particularly inflammatory conditions. So remember that inflammation has an effect on a number of our serum iron proteins that we're looking at, and so inflammatory disorders can affect hemochromatosis as well. Also diet and other environmental influences and other autoimmune conditions as well. It's very commonly misdiagnosed, and I think I mentioned yesterday that my sister-in-law has hemochromatosis, and she was diagnosed in her mid to late 40s. And it was mainly due to the fact that as we will see in a little while, the clinical signs and symptoms of the disorder are quite diffuse, and so it is actually quite hard to diagnose, particularly when our standard screening tests, such as the FBE, come back normal. So where do you go from there, really? It's quite difficult to diagnose and often takes a little bit of time. So now these two animations that I keep talking about. So this is just showing you what the HFE gene does in the cell, so what its purpose in the cell is. So this is in the normal situation. So here we have our transferrin receptor 1, which is the membrane transporter protein that allows transferrin to enter cells. So under normal situations, when there is enough ferritin within the cell, then the HFE protein, which is also in the cell, binds with beta-2 microglobulin. And the beta-2 microglobulin, if you like, transports the protein to the cell membrane where it helps it to bind to the transferrin receptor 1 on the cell surface. So what this does is this reduces the ability of the transferrin binding receptor to bind to transferrin. And at the same time, once this happens, what happens is that the HFE protein is released. And what's not on this animation is the fact that that HFE protein then binds with transferrin receptor 2. And in that binding, the transferrin receptor 2 is activated to signal the hepatocytes to produce hepcidin. So it's actually that binding of the HFE protein to transferrin receptor 2 that actually signals the production of hepcidin. So HFE protein is responsible for binding to transferrin receptor 1 and reducing its ability to transport transferrin into the cell, and it's responsible for signalling the production of hepcidin. So there's a bit of a, it has two roles there. So what we find in somebody who has hemochromatosis is our transferrin receptor is still there on the membrane, so transferrin receptor 1 and transferrin receptor 2 is still there on the membrane as well. But what happens is that the gene codes for an abnormal protein that can no longer bind with beta-2 microglobulin, and that's the issue. So if we don't get the HFE protein binding to beta-2 microglobulin, then we don't get the HFE expressed on the cell surface. It's not able to bind with the transferrin receptor, and then it's not able to be released and to bind with transferrin receptor 2. So then we don't have the transferrin receptor bound to stop transferrin entering the cell, and we don't have the signalling process for hepcidin production. And so what happens in the gut, we have just all of the iron that is available being absorbed through the enterocytes into the plasma, and then within the body, the cells turn into little iron sponges, and they just soak up all of the iron that's available to them, because there is just the brake on the amount of transferrin coming into the cells, the brake on the amount of iron being absorbed into the body has been removed. And so what we end up with is very much increased iron stores in our cells, and so we have increased ferritin and hemosiderin. So, so these are the two things that how the iron is initially stored, but what then happens is that when the ferritin stores in the cell are replete, when the hemosiderin is replete, then what happens is the cells still allow iron to enter into them, and it just stays as free iron ions within the cell. And this is where the damage happens, because they become free radicals. And so they are able to, in the presence of oxygen, they are able to generate superoxide and other free radicals, and this causes peroxidation of all membrane lipids. So it's not just the cell membrane that can be damaged, but all of the membranes of all of the organelles within the cytoplasm. And so the mitochondria is damaged, the nuclear envelope of DNA is damaged, but most importantly, the lysosomes are damaged. And so those little packets of enzymes that are held and protected, or the rest of the cell is protected from by their little membranes, they are damaged as well, and so you get release of the enzymes, the proteolytic enzymes within the cells, and this is what causes the cell death. So initially it is our macrophages and hepatocytes that are most initially affected by this and become overloaded with iron, and then it becomes every cell in the body, because every cell in the body uses iron. So most cells have the potential for iron damage. Having said that, there are a few organs in the body that have a predilection for iron, so they use a lot of iron, and so the clinical signs and symptoms tend to be associated with these organs. And so you can see that the skin, the reason that we've got the skin in this list is because we can see changes in the skin. So remember, not all clinical signs, we can't see all clinical signs. If they're internal, then we can't see them. That's where the symptoms come into play. You can also see that the liver, of course, is most affected because that's where a lot of our iron is stored anyway. The pancreas and the heart are also very commonly affected. And so as the pancreas is damaged, then we can end up with diabetes. As the heart is damaged, we can end up with congestive heart failure. As the liver is damaged, we can end up with liver failure. So it's really not a very nice condition to get. As it says down the bottom there, early treatment can slow the pathogenesis, and the treatment is actually quite straightforward. But the trouble is identifying that somebody has hemochromatosis in the first place. That seems to be the hardest thing. Because, as you can see here, the clinical signs and symptoms are quite vague. Because when you think, you know, you might have a bit of abdominal pain, you might have a bit of breathlessness, you know, it's really nothing all that brilliant. It's interesting. I don't think I've ever sort of really seen anyone with that bronzing. I guess people might just think that you've held on to your suntan really well. I know with my sister-in-law, she didn't ever have any bronzing of her skin, but she was initially diagnosed as having rheumatoid arthritis, so she had a lot of joint pain, and then they thought she may have had some sort of an autoimmune thyroid condition because of she had hypothyroidism and weight loss. So these are all quite vague symptoms. So coming to laboratory findings, we can see that, as I said, the FBE and blood film are normal. And it's not until somebody has the sense to go ahead and do iron studies that we see that things are certainly not normal at all. And so you can see here that all of our iron indicators are increased. Our total iron binding capacity can either be normal or decreased depending on how much iron is absorbed into the system, so how severe the hemochromatosis is. And so you can see that all of these indicators show us that there is plenty of iron in the body. The body is chock-a-block full of iron. Bone marrow analysis is often done with hemochromatosis because of its very vague symptoms. And so if we do have a bone marrow analysis, what you see is just massive iron deposits. Unlike sideroblastic anemia, where we get the ringed sideroblasts because we've got the iron in the normoblasts around the nucleus, what we find with hemochromatosis is it's the macrophages, the tissue macrophages that are full of iron. And although we do have iron in the erythrocytes as well, but it's mainly the tissue macrophages that we see it. So we definitely do need to have molecular analysis here because we need to identify the gene mutation. And so that would be, once in the laboratory we had diagnosed that it was hemochromatosis, then a sample would be sent along for molecular analysis. Also, we'd have familial testing as well. This is a really good way of identifying people who are asymptomatic but do carry the gene for hemochromatosis, so at least they can be followed and made sure that they don't develop the condition. The treatment is really straightforward, as I said before. Basically what you do is you remove the iron from the body. The way you do this is the easiest way to do this is to take blood from the patient. So instead of giving the patient a transfusion, you actually remove blood from the body, which of course is regular phlebotomy. So what we're trying to do here is to induce a mild anemia. So why do you think we're trying to induce a mild anemia? What effect would that have in the iron within the body? So it's the using up more iron bit, because what is the issue in hemochromatosis? It's all that stored iron. What happens as soon as we start becoming iron deficient? What's the first stage 1 of iron deficiency? What's that? Can you remember? So we use our iron stores, don't we? Okay, so if you induce a mild anemia, then you're going to unlock all of that iron that's been stored away. Okay, so that's usually what happens. Often we do get organ damage, and so that has to be treated, of course, depending on which organ has been damaged. If we have transfusion-related overload, you can see that the treatment for that is very different. So where we get transfusion-related iron overload is conditions such as transfusion-dependent thalassemia, and we'll be looking at thalassemia next week, or it could be somebody who has bone marrow failure, which is known as aplastic anemia, or it could be, let me see, somebody who has some other condition of blood loss or reduced, some other anemic condition that can only be treated by transfusion. And the issue with transfusion-related iron overload is that you're bypassing the gut absorption, which is our main mechanism for regulating iron coming into the body. Okay, so you're bypassing the DMT1, you're bypassing ferroportin. You're going straight into the blood vessels. And so there is no regulation there. And so we tend to get increased iron in our bodies. And so the way that we deal with that is we use what we call iron chelating drugs. I talked about this when we were talking about sideroblastic anemia yesterday. So desferrioxamine is the main one. And what happens is desferrioxamine chelates the iron, so it binds with the iron, and then that is removed from the plasma and it's excreted from the body in urine. The trouble with desferrioxamine is it is a subcutaneous injection, and so it's not particularly pleasant to keep on having to have these subcutaneous injections all the time. So there are other oral iron chelators coming onto the market that are certainly more acceptable to the people who have to take them. So this is a slide that I've also introduced this semester that we didn't use last semester, and it's mainly a slide for you to fill in. I'm not filling this in, this is for you to fill in. So after each of our learning modules where we've learned about a particular condition or group of conditions, what I'd like you to do is to go back through your notes and make a list of the individuals at risk of developing a particular condition and why they are at risk. So I really want you to get into the habit of whenever you make a statement about something, you justify that statement, okay? Whenever you identify that this is so, or this is what we do next, you have to justify it. You have to explain why, okay? All right, and so there's a summary for you, plus some review questions. Has anybody got any questions before we go on to the case studies? No? Okay. So that's taken a little bit longer than I was hoping. Is there anyone here who has already completed the case studies? No? Okay, so if you've got a couple, so if you've completed the case studies, then you can come up and show your answers to me and leave, if you like, and everybody else can just get into groups. I don't care where you sit. You can sit on the stairs here, you can sit on the stage, you can sit where you are in a group. I don't really mind. And if we spend about, 10 minutes or so looking at the case studies, and then we'll have a wrap-up at the end, okay? I can just interrupt, I was just asked a really good question. So if you'd like to answer, listen to the question and the answer. The question was, so in hemochromatosis, the FBE is absolutely normal. There's no poikilocytosis, no anisocytosis, nothing like that. In sideroblastic anemia, of course, that's where we have the dimorphic population, you might recall from yesterday. So we have some of the cells have been, one clone of cells is affected by the enzyme disorder and another clone isn't. So the difference between the two, even though they are both considered to be conditions of iron overload, the difference between the two is with sideroblastic anemia, the defect is with the enzymes that are associated with incorporating iron into the red cell. With hemochromatosis, the defect is around iron regulation itself. Okay? So one is to do with the cells, one is to do with iron. Okay, is that clear to everybody? Yeah? A few confusing faces there. Need to think about that a bit more? Okay, so these tutorials, these case studies were all based around iron studies, and as you can see here, iron studies, serum ferritin in particular, is our differentiating feature for microcytic hyperchromic anemias. So any time you have, in your provisional diagnosis, any time you have a microcytic hyperchromic anemia, then your next stage would be doing iron studies. Okay? Because, and the main reason for that is because iron deficiency anemia is the most common cause of microcytic hyperchromic anemia and is quite easy to fix. And so if you've got iron deficiency, then the treatment is very straightforward, off you go. If the ferritin tells us that the patient doesn't have iron deficiency, then we have to think a bit further. Okay? So that's why iron studies are your first further test when you've got a microcytic hyperchromic anemia. So when we're looking at anemias differentiated by iron status, iron deficiency anemia is first, then sideroblastic anemia, and I guess really anemia of chronic inflammation, infection, disease, whichever one you like to see. And I've got them all listed there because depending on the text you read, depending on the website you're looking at, they will use these three terms and they'll use them interchangeably. So this really should probably be up here, particularly in Tasmania where we have an older population, because we do tend to see chronic illness in older people, because chronic means that it's been around for a long time. And so the older you are, the longer you've had the illness usually. So we do see quite a bit of this in Tasmania. We don't see as much sideroblastic anemia or thalassemia in Tasmania. However, if you were in Melbourne, where there's quite a high Greek population, quite a high Asian population, then you would find thalassemia is a lot more common. Okay, so again, it really depends on where you are as to the prevalence of a lot of these conditions. So our first case study, female 45 years, post-hysterectomy, complains of fatigue. So looking at what the doctor has requested, we can tell that this doctor thinks that this person probably has an iron deficiency anemia. Given her age, the fact that she's post-hysterectomy means that she's probably had some issues with blood loss. That's usually why hysterectomies are performed. It could be that the woman has extremely heavy periods, or she has very close together, so they're very prevalent. So she's losing a lot of blood and it's unsustainable, so they whip out the uterus and that stops the bleeding. So the doctor's just thinking, yep, could still be to do with her issues around why she had the hysterectomy, so he's ordered, or she has ordered, FBE and iron studies. So we've got our FBE here. And so what we want you to do is to describe the red cell morphology that's seen under the microscope, summarise the results, suggest a provisional diagnosis and justify your choice, and predict the results of the iron studies. Okay, so I've just noticed that it's nearly 10 to 2, so I think everybody did this case study quite well. Did anyone have any questions around this case study? No? Excellent. So we'll just whip through it. So basically what you've got here is a fairly typical microcytic hyperchromic blood picture. There is a little bit of a dimorphic picture there. There are a few normalish looking cells, but there's a bit of polychromasia. We've got quite a bit of anisocytosis and poikilocytosis. There's a few elliptocytes. When they get really thin, we actually call them pencil cells because they look just like pencils. So the red cell morphology, hopefully you wrote something like this. Yeah? Something along those lines. That in various combinations of permutations is a fairly standard microcytic hyperchromic picture that you'd see in iron deficiency. So our provisional diagnosis based on our FBE results, so our FBC results, so the haemoglobin was low, so we've got an anaemia. The MCV is low, therefore it's microcytic. The MCH, I think, was also low if you did the calculations, and also the cell morphology certainly supports that. So we're thinking that it's iron deficiency anemia, so what would we expect in our serum iron studies? This is why we think it's that. The most common cause of microcytic hyperchromic, especially in this population. So if we think it's iron deficiency anemia, what result would you expect for serum iron? High, low or normal? Total iron binding capacity? High, low or normal? Remember, when we have iron deficiency, the total iron binding capacity and the serum iron are opposite each other, because when you think about it, this is telling you how much transferrin is free. And if you've only got a little bit of serum iron there, then you're going to have a lot of free transferrin. So that means it has the capacity to bind lots of iron if it was given lots of iron. Okay? There's a lot of it free. Does that make sense? Yeah. It's a thing that people do get a bit tricky. It's a bit tricky to get your head around. The percent transferrin saturation is going to be low because there's lots of transferrin, only a little bit of iron. Okay, so the percent saturation is only going to be low. And the serum ferritin is low. Does that make sense to everybody? Yep. Mandrel, that makes sense to you? Yep. Good. Carmen, makes sense to you? Good. So these were the actual iron studies. So that follows our predictions, and so we would give this person a diagnosis of iron deficiency anemia. Anyone got any questions around that case study? No? All right, case study number 2. So the hint here is the fact that this woman has rheumatoid arthritis. Now, I know I probably put a bit of a red herring in with the hemochromatosis. So you may think, oh, okay, joint pain, arthritis could have hemochromatosis, but does this blood picture sit with a hemochromatosis? No, it doesn't. So immediately you can cross out hemochromatosis. Okay? So we can see here the doctor has requested a fairly standard panel of screening tests because they're obviously not all, they don't really know what's wrong with this person, so they've just done this standard panel of screening tests. And we can see that everything is normal except for the FBC. So again, what's abnormal here? Hemoglobin, MCV. So what's our provisional diagnosis? Yeah, so microcytic hyperchromic. MCH, I haven't got my reference intervals. Is that low? Somebody? Yes? So microcytic hyperchromic anemia. I'm hopeless at remembering reference intervals. That's why I don't get you to remember them. So this is the red cell morphology. This is a lymphocyte. This is a small lymphocyte. Interestingly, on here, just thinking that we'll be actually looking at red cell inclusions in a couple of weeks' time. See these cells here? This one here? This one here? This one here? They all look like they've got red cell inclusions. Definitely this one. And that little inclusion there is called a Howe-Jolly body. And so you see those sometimes when the spleen's not working all that well. But we'll get to that in a little while. So these were the descriptions here. So the cell morphology, I think microcytic hyperchromic, but looking at the results, the anemia is really not all that amazing. It's a fairly mild anemia. So if we've got a mild anemia in a person of this age, what do you think it could be? What's the most common cause of microcytic hyperchromic anemia? Iron deficiency. So the first thing you would be doing is iron studies. Yep. So provisional diagnosis is based on your FBE results. Further diagnostic tests, the first thing I'll be doing there is iron studies. So what other possible health conditions can give us a microcytic hyperchromic blood picture. We've got iron, I'll get there in the end, iron deficiency anemia, sideroblastic anemia, chronic inflammation, that beautiful Greek word, thalassemia. Okay, so abnormal hemoglobins will also, particularly thalassemia, can also give you a microcytic hyperchromic anemia. So that was in our list before. Okay, so there's a number of possible health conditions. So the way that we can differentiate them is looking at the iron studies. And so you can see here all of our main culprits. So here's iron deficiency, thalassemia, anemia of chronic inflammation, sideroblastic anemia. So you can see that iron deficiency is the only one where we have a reduced serum ferritin. It's increased in all of the others. So, and serum iron is also low here, and it's low in anemia of chronic inflammation. It's normal or high in the other two. So interestingly, see here we go, serum iron is low, IBC is high. So remember, this is what we get in iron deficiency. When we come along and have a look at anemia of chronic inflammation, what's going on here? We have low serum iron and a low iron binding capacity. So the reason for that is because transferrin is, again, it's an acute phase protein, and so it's actually reduced in inflammation. And so if we've got less transferrin, and you can see here, if